Don't ever let them bring you down, cause then you be on a level. Listen, I'm never giving up. Stand your ground, don't be too comfortable or too settled. Listen, I'm never giving up. When you hit rock bottom, it's only one way to go. Listen, I'm never giving up. Everybody got problems, how you handle them, no. Yeah, listen.
Hey, I'm John.
And I'm Jonathan.
Welcome to the Formula.
What's up, fam? What's going on, John?
What's up?
What's up, man? We got a very special guest with us today. We haven't had a guest in a while, huh?
It's been a minute, yeah.
We've been rolling solo, man.
Yeah, it's been a minute.
But we have a very special guest. A guest is very important to me. Her background is very important to me. My wife's a registered nurse as well, so I understand the struggles. I understand the struggles that these ladies and men go through on a daily basis. I understand the mental capacity that they have to have, the mental toughness that they have to be in their profession, man. So I'm very excited about our guest today, Miss Registered Nurse Maria.
Hey guys, how y'all doing today?
Let me give you applause. Okay.
Yeah. How you doing today, Miss Maria?
I'm doing well, thank you. How are you guys?
Good. We're good. Thank you for hopping onto the podcast, especially in short notice. Really appreciate that.
Absolutely.
So let's start with, so you're a registered nurse. Let's start with your background, where you're from, and where'd you get your degree?
Okay, so I'm originally from Queens, from Far Rockaway. Whoop, whoop.
All right.
I got my bachelor's from Stony Brook University, and I've been a nurse for 11 years now. I've done different things in my nursing career. I've worked at the bedside. I've done home care. I've done occupational health. I have done oncology. And currently I'm doing primary care case management. So yeah, I've been kind of all over the place. I've done travel nursing as well.
Okay.
So yeah, right now I'm steady in Virginia Beach.
Cool.
And maybe or maybe not staying here.
So when did you move down south?
I have been here since 2015. I came down here as a travel nurse.
Okay.
And ended up meeting my soon-to-be ex-husband. And decided to stay. So I've been here since. And it's cool here. It's just, hard. I don't have John here. I don't have my parents.
Right.
Siblings. So,
Yeah, I'm kind of trying to get her out of VA, but we'll see how that goes.
Hey, hey, North Carolina is amazing.
You're always welcome to come.
Charlotte is amazing. Maybe you should check it out.
I'm definitely thinking about it. That's for sure.
So how do you all know each other? You guys go to school together? How
No, her parents and my parents are like besties.
Okay.
Yeah.
So
we've known each other all our lives.
Yeah, we've known each other since like little kids, like grade school. So, and then we kind of like was like kept in touch, but not really, but kind of sort of, but not really. Then, like I think high school. I think when I graduated high school, that's when we really like linked up hardcore, and then we've been tight ever since.
Yeah.
That's awesome. So what do you like about nursing? I know there's a lot of things that people don't know about nursing, but what is it that made you gravitate towards nursing?
I've always been a helping person. I always wanted to either help or teach, and gratefully being a nurse, I can do both. So that's really what gravitated me towards it. Right now in my position, I get to do a lot of teaching to patients and to staff. So that's really great for me because I'm a talker. I love teaching people what I know, and I love learning from others. So yeah, that's what I really love about it.
So you're going to teach us a little something about colon cancer.
A little something, something.
You want to explain to our audience first of all, what's the colon? Where is it?
Okay, so colon is part of your intestines. It's basically the last part of the digestive tract. And it's a very important part because that's where most of our waste is eliminated, through the colon. A lot of times people develop different disorders that increase the risk of colon cancer. Sometimes it's hereditary. A lot has to do with diet as well. People who have like low fiber, high fat diets, they're at greater risk of colon cancer. Have changes in their bowel habits, constantly having diarrhea or constipation. There are a lot of people who will go 10 days without having a bowel movement and don't think anything of it. Yeah,
10
that's a
days?
problem.
Damn.
That's a problem. So there's a lot of things that affect the colon that causes colon cancer. Other disorders, inflammatory disorders like Crohn's disease, ulcerative colitis, those definitely increase the risk of colon cancer as well. It's typically found in people older than 50. However, it can happen in anyone. As we know, I'm not sure if you guys know, but the gentleman, Ahmad Real Givens from Real Chance of Love, he was 33 when he was diagnosed with stage 4 cancer and died.
Wow.
Stage 4 colon cancer, yeah. So it can happen early. So it's really important for us to pay attention to our body, because our body will tell us a lot of things that we just don't really listen to. But it will tell us when there's something wrong.
All right. So what age should we start getting screened for that?
So typically, people are screened over the age of 40. If you have a family history, if you have certain conditions like Crohn's or ulcerative colitis, they'll screen you earlier than that. Discomfort, like if you're having symptoms, if you become symptomatic, they want to screen you earlier. Some providers do it differently. For me, where I work for the Department of Veterans Affairs. So we start screening at 40 with colorectal cancer screenings. And basically what that is they send you a kit to your home and you collect a sample of your stool and they test it to see if there's any blood in the stool. Some patients will say, I have bleeding from my rectum, or I notice blood in my stool. So we'll send them those kits to test for that. If the test comes back positive, then we will set them up to have a colonoscopy. And the colonoscopy will do all the determinations on whether or not they have polyps, whether or not the provider sees something that could possibly be cancer, and they'll do a biopsy of the samples they collect from the colonoscopy. So typically 40, but if you have a family history or other conditions that put you at higher risk, they may test you sooner than that.
But it's not, is it like genetic? Can it be like hereditary?
It definitely can be hereditary. If you have a family history, you are definitely at a higher risk. Absolutely.
So once someone is diagnosed, is there any kind of like treatment, medicine? Is chemotherapy an option? Like what happens?
Well, it depends on how it's staged. Well, first, typically what happens is when they do the colonoscopy, they may find a polyp. Typically, polyps are non-cancerous, but over time, if they become mutated, the cells start to develop and overdevelop, which turns into a tumor. And they'll biopsy that polyp to see if there are cancerous cells. Based on that, the biopsy, they'll send you for a PET scan because you may see tumors growing other places in the body. So they'll do what they call a PET scan to determine where the cancer is in the body.
Okay.
And then they'll stage it. Stage 1, that's obviously early stages. They can do minor procedures, like a laparoscopic procedure to just remove the polyp that's causing the issue. Some more advanced procedures called like a colectomy. They can do a partial or full where they remove a portion or the entire colon from the body to get rid of the cancer. it's more advanced, like in stage 4, chemotherapy is an option, immunotherapy, things like that. But once it's at stage 4, it can, a lot of the time they can treat it with removing the colon and chemotherapy. But sometimes they have to go to the route of palliative care, which is basically care to make the patient comfortable because it has spread so far that there really isn't anything they can do at that point. So.
And what does a polyp look like? What can you explain what a polyp?
So think of like a keloid. Think of a keloid. It can be a small one. It can be a big one. Again, sometimes they're non-cancerous and they can be left alone. But if the doctors do notice that, they will, screen you more frequently to make sure that there aren't any changes to that polyp. You can have that polyp for your lifetime and nothing be wrong with it. Other times there are changes. The only problem with it, though, is sometimes, especially in the early stages, you don't have symptoms. So you may not have any symptoms at all. For others, they will. And that's why it's really important to pay attention to your body, because your body is going to tell you if something's wrong. A lot of the time, symptoms that people will have of like abdominal discomfort persistently, cramping, gas, just feeling like you can't empty your bowels, consistent diarrhea, again, or constipation, fatigue, weakness, unexplained weight loss. Those are all symptoms that can occur. So you definitely, if you notice that you're having those type of symptoms, you want to mention it to your doctor. And us as African Americans, we are at a higher risk of developing colon cancer. So it's really important for you to advocate for yourself if you are having those type of symptoms. Especially younger people, they try to brush it off. Oh, you're too young for that. Listen to your body. Get a second opinion because they could be missing something.
So you kind of alluded to this. So it can spread. Like if you get colon cancer, it can spread to other organs.
Oh, absolutely. Actually, I have a patient now that I'm dealing with who had colon cancer years ago. He went through his treatment, went through chemotherapy. He was in remission for probably 10, 15, maybe 20 years. And all of a sudden he's losing weight unexplainably. He's having this just general malaise, discomfort within his body. They can't explain what was going on. So they started running all these tests and come to find out now he has metastasis to his lungs. So now he has lung cancer. So
do they feel like that was, is that separate from his colon cancer, or do they feel like it was
possible? It's possible for it to be separate from the lung cancer, from the colon cancer, but he's still in the testing stages. So that's the point where we are now. Is it a colon cancer with metastasis to the lungs, or is it lung cancer?
Do you know if he smokes or not?
He is a non-smoker. Family history. Yeah. It was hereditary. So yes, he's a great person, but he's going through so much right now. I just feel so bad. But as a nurse and as a professional, I have to keep those professional boundaries and just advocate for him, because as his case manager, my job is to make sure that he is receiving the services that he needs. So making sure he's getting the appointments with his GI doctor, making sure that we set him up with an oncologist to review his case and make sure he gets the necessary treatment that he needs, making sure that his primary care doctor is putting all these orders in for him to see these specialists. So I got a big job.
Yeah, absolutely. Absolutely. This is amazing, amazing, man. So, what is that road to recovery like? After they've gotten their treatment, they've been diagnosed, they got the treatment. What's that road to recovery like?
It can be good for some. For others, that the prognosis is not great, and so the goal is comfort. making sure that they have the pain medications that they'll need because they will be in pain, and just doing those things that they need at, towards end of life. For those who have better outcomes, for instance, there are some patients who, again, will have to have surgery to remove a portion of the colon, and that's considered a colectomy. And sometimes what they'll need to do is form an ostomy. And basically what an ostomy is they bring part of the colon to the skin. They bring it out of the body so it can empty out to give the rectum and the other portion of the colon that was surgically removed time to rest and heal. So they'll bring it out to the surface of the skin, and the stool will be emptied out into a bag. It can happen at different portions of the colon. And so the consistency of the stools will be different based on where they remove the colon. So it can either be watery stools or it can be formed stools coming from the bag. And then if it's healed enough, they can connect the colon back together. And, people have great outcomes. Sometimes that can be a permanent solution. So, it all depends. Some people go into remission and don't have issues after that. It just all depends on the staging of it. And that's why it's really important to get screenings and to pay attention to your body, because those symptoms can be telling you, hey, something's going on, and it can be caught early. When you don't pay attention to those symptoms, it can progress and progress. And you get a worse outcome. So
modern medicine is amazing.
Yeah, it's crazy.
Yeah,
Wow.
Especially you'd be surprised at things we see, especially working at the bedside. Man, I have seen some things.
So they could just, cut your colon in half or whatever and stitch it back together. So they could really just go in there, get out what they need, and then glue you back together.
Yeah, and sew it up to a different portion of the colon, or some people remove it altogether. It all depends on the situation on how bad the cancer is.
Well, I knew about the bags, but I just never really thought about how that is constructed.
Right, like the process.
And a lot of the times
Yeah.
you see those bags, it's because the patient has really bad Crohn's or really bad ulcerative colitis. So colon cancer doesn't necessarily mean you'll end up with one of those, because you may not need surgery, but that is a possibility.
Gotcha.
So let's say someone gets colon cancer and they beat it, they're a colon cancer survivor. Is it possible for them to get colon cancer again after they already beat it?
Absolutely, because cells can still be hiding around and, get missed and start to replicate and cause tumors all over again.
So it could be years down the line.
Oh, absolutely. Absolutely. Cancer is a tricky thing. It really sucks. It does what it wants to do. It comes around when it feels like it and doesn't give you any warning sometimes. So yeah, that can definitely happen. I've seen it happen.
Have you had patients reject your advice?
All the time, on any and everything.
So you have anti-medicine patients. It's I have this thing, but I don't want to take any prescription. I don't want to do anything.
Absolutely, especially when it comes to vaccines. I understand COVID, was a little different and people are skeptical about that, but things that have been around for a long time, for instance, shingles. When you get to a certain age, you want to make sure you get your shingles vaccine, because you don't want to end up with shingles. Shingles is painful and not fun to have. And I have had so many patients say, I'm not getting that vaccine, and then call me months later, Nurse Parker. I got shingles now.
Oh, no.
Well, you better be lucky you don't get it on your face, because those patients could end up blind, too, from getting it on their face. So, yeah. Oh, yeah. A lot of patients don't listen and then end up in trouble. I'm like, man, I should have listened.
Mm-hmm.
And so then that's when they want to follow, a plan or something. And we always encourage patients to advocate for themselves, be a part of their healthcare, because you can't just depend on what I'm saying. You have to be an active participant in your own care. So, just take the good advice when it's given and, do what you feel is best, but, don't just negate it altogether. That's never good.
So anyone who's got like any kind of pre-existing condition, any kind of cancer, they should get vaccinated. Is that what you guys recommend? So if someone has colon cancer, they should get the COVID vax?
I definitely believe anyone who is currently receiving any kind of immunotherapy because they have a low immune response to viruses and things like that. So patients who are receiving chemotherapy, patients who are HIV positive, who have active symptoms, things like that, because, they're at higher risk. When you're immune compromised, you're at higher risk of developing infections and, catching viruses and things like that. So we would definitely recommend it to those patients.
Now, you spoke a lot about advocacy, and it's very important, especially in your field, in the medical arena, I should say, and it's very important for people like yourself to help advocate for those patients. Now, tell me maybe a story about when you had to actually step in, because I know you guys have to do it a lot, especially African American nurses have to step in and advocate for a patient. I mean, it don't have to be an African American patient, but most of the time that is the case where you have to advocate for that African American patient, because we know that they don't treat us the same.
Absolutely.
And I'm not saying every doctor, every nurse don't treat African Americans the same, but they are, because my wife actually dealt with it when we was giving birth to my daughter. So can you tell me maybe a story, something that you had to actually step in to be the voice of reason to the doctor or the nurses?
So actually, I have a story about before I even became a nurse, while I was in nursing school. I was working in a group home with adults who have developmental disabilities. Now, clearly, they cannot speak for themselves. Okay, they can tell you certain things, but obviously, if it's something medical, they did not understand anything like that. So one of the guys I cared for, my sweet Jay, rest in peace, he went away to camp for the summer. When he came home, I just noticed that one of his arms looks bigger than the other. It was just random. Like, why does his arm look bigger than the other? So I mentioned it to the nurse who cares for him. She's like, oh, I don't really see anything. I said, no, something's not right, And one night I decided, it was time to give him a shower. So as I was giving him a shower, I noticed a lump under his arm. It looked like a boil, but it didn't seem painful to him when I touched it. So I went to the nurse again. I said, listen, something is not right with Jay. I think we need to take him to the doctor. And she knew I was in nursing school. So I think at that point, she was like, okay, well, maybe let me pay attention to this. So we ended up taking him to the doctor. And thank God I was the one who took him to this doctor's appointment. The doctor came in and I said, something's not right. One of his arms is bigger than the other. And the doctor looked at him, had him point his arms out and was like, oh my God. That was like what came out of this man's mouth. All he said was, oh my God. It turned out he had non-Hodgkin's lymphoma, a form of cancer that affects the lymph nodes. And he ended up going through chemotherapy, which was awful to watch. It progressed his Down syndrome, which progressed his dementia. And unfortunately, he ended up passing a few years later. He went into remission from the non-Hodgkin's lymphoma because gratefully that is a type of cancer that can go into remission and have good results, but because of his other health conditions, it just the chemotherapy just deteriorated his health. So, yeah. And till this day, I still communicate with his family because they were just so grateful, advocated for their brother. You know, when no one else would have noticed anything like that or paid that close attention. So it's really important for nurses to have really good critical thinking skills, because if you don't, you're going to fail someone.
Yeah, we hear those stories a lot. You know, my wife deals with it a lot. So I just wanted to get your thoughts on it as well.
Yeah, it's, you know, we have to, but you know what's funny is sometimes I have experienced African-American patients don't want an African-American nurse.
Really?
I have experienced that. I have it, and it's usually Black males that want the white nurse.
Really?
Yes.
Because I was specifically looking for a Black doctor. I'm like,
I don't know what it is. I don't know if, you know, older Black men have this thought in their mind that we're not as educated as white women, or what the case may be. But I have experienced that. I've definitely experienced that.
That's interesting.
That's crazy to me.
That's very interesting.
Yeah.
So, it all depends on the patient, their personality, their thoughts, and what they want. But yeah, it's interesting how some patients don't even want us to be their nurses. But I advocate for my patients, especially when I see something wrong. I remember one time I was working at an urgent care, and this young lady came in. She had just had a baby, and her blood pressure was through the roof. And the doctor was a white male, and he basically gave her some blood pressure medication and was like, follow up with your primary care doctor. So I went in to give her the medication to take, and I told her, go to the emergency room right now and go back to the hospital where you had your baby and ask to be admitted back onto that ward, because, girl, you might be having a serious health crisis. So you need to get back to that hospital. And she did that. And she was going through preeclampsia.
Wow. Like, come on.
And it, like, for me, I'm like, oh my gosh, how could he not know that? But then I think too, you know, when you work in certain fields, like me, I'm a med-surg nurse, so I really deal with the adult population, cancer, heart disease, diabetes, things like that. I don't really do women's health or, you know, OBGYN. That's not my specialty. But because I went through that experience myself, I knew I had to tell that girl that information, because that could have been a really bad situation. Good thing, you know, I know what my symptoms were. I know that I needed to advocate for myself. And I worked at a facility that specialized in maternal fetal medicine, especially, you know, people with high risk pregnancies and things like that. So, you know, I got the care that I needed right away. But had I not gone through that experience myself, I don't know if I would have been able to advocate for her that way, because that's not my specialty.
Right.
So I thought, okay, well, maybe he just doesn't know. And that's scary, though. You know, doctors are working in these urgent cares. People are coming in for different things, and they could be leading them right to their deathbed.
Right. Yeah, that's what I was thinking. I was the same thing.
Yeah, I was gonna ask you, are nurses at war with doctors? Because it seems like all right, so doctors don't know anything, because that's my assumption, is that they don't know nothing.
Doctors give orders, nurses do the job.
Yes.
Okay. Doctors could never do what we do.
No.
So doctors don't really save lives.
No, they don't.
The nurses do everything.
Right.
The nurse is the one. If someone needs to be resuscitated, the nurses is doing that.
It's just the doctors going off the algorithm and telling us what to do off the algorithm. They're not doing any of the hands-on stuff.
Right. Yeah. And it's crazy that he go to school for all this time and he didn't think about like, all right, she was pregnant. Now just her blood pressure is up.
Right.
Even
me and you would like kind of connect the dots there.
That's the stuff that just blows my mind when I hear some of these stories that it's not, they don't even follow the path of like you said, the algorithm though, like you don't follow the path of, okay, this can happen. This is a cause of this. So this might happen.
Right.
You know, she was pregnant. She had a baby a few days ago. Now her blood pressure's up.
Right.
Okay. What's the cause of that? And what can be the leading factor after that? Like, how can he not? I don't get it.
A simple question. Did you have this issue before or during pregnancy?
Mm-hmm.
That simple question could have led him to be like, you need to go straight to the emergency room,
right,
or go back to L&D where you had your baby because something could be really seriously wrong.
And it took registered nurse Maria.
Mm-hmm.
Yes, love it. Yes, that black girl power.
Honestly, had I not gone through that experience, I don't know if I would have known to ask her those questions. I mean, I think I would have.
You probably would have, because your woman intuition would have did that,
and your educational background.
Yes.
So
right.
I think like when patients tell me things, I don't just be like. And I know a lot of nurses do this, and it's sad. They're like, okay, we'll let the doctor know, and we'll follow up with you.
Mm-hmm.
No, ask questions. Why? How long has this been going on? When did it start? Are there anything that precipitated this problem? Like, you ask questions.
Right.
You don't just like, okay, you're telling me this. I'll wait for the doctor to respond. Ask questions, because you as a nurse could probably solve the issue before the doctor could even get to it.
All the time.
Mm-hmm.
And like, what's one of the biggest fights you had? Like, I wouldn't say like it don't have to be physical, of course, but what's one of the biggest fights you had with a doctor? Like, hey, you have to do something. We have to order this. Like, something has to happen right now, or something's bad gonna happen, and it's gonna be on your hands.
Oh yeah, I had this situation in when I was at the bedside. We had a patient who was on dialysis. And, obviously dialysis is used to filter the blood of all the toxins because the patient is unable to filter it, which the kidneys does the filtering. Mm-hmm. And obviously her kidneys do not work. So she has to go to dialysis. And they decided to give this woman pain medication towards the end of her session of dialysis, which means this medication is not going to filter out of her body for a long period of time. And this patient was very lethargic. And we're trying to tell the doctor, you need to send her back to dialysis. Something is not right. At least get her up to, ICU or something. This woman is way too lethargic. We cannot manage that on this type of floor. Doctor didn't listen. This happened probably about 8:00 at night. All night we were just, me and other nurses, we were, just checking on this patient. No change. Calling the doctor all night, and they would not respond. 7:10 in the morning. Now 7 o'clock is change of shift.
Yeah. The
tech went in to do her blood pressure, and she said, "This lady is in there moving funny. Can y'all come in and check?" This lady was in cardiac arrest. And she ended up dying. She ended up dying that morning. It was so sad because something could have been done. And it wasn't done. And maybe she would have had the same outcome. But the fact that we were telling the doctors that something needed to be done and nothing was done, and then she ended up dying, we never know what the outcome could have truly been. So we see a lot. We go through a lot. I feel like nursing, especially at the bedside, has given me PTSD. And I can't imagine with the nurses who are at the bedside throughout COVID. I know they have PTSD, and it's probably 10 times worse than I ever experienced. I can imagine because they are seeing a lot more death than I probably have. But yeah, nursing is
So how you deal with that? Seeing that much sickness, that much death?
For me, when I started having nightmares about patients who died chasing me around, that's when I knew I was done with the bedside. I miss it. I do miss it because I miss the tasks. I don't really miss the death and all the sickness. I miss doing all of the tasks. But when I started having nightmares about this one particular patient, and him and I was so cool. I had a patient, Mr. Camacho. He did not speak any English, but I knew some Spanish, so I was able to communicate with him. He would yell, scream, cuss out all the other nurses, but when he saw me, he would calm down. He was an alcoholic, and he died of liver failure. And the night he died, I was not there. But when I came back the next morning and found out he died, every night after that, I had nightmares that this man was chasing me around the nursing unit all night long. Like, it was bad.
Wow.
So I knew at that point, I'm like, okay, I think I need to take a break from bedside nursing. So I started doing home care. And then home care was a whole nother.
I bet.
Yeah. Seeing how some people have to live.
Yeah. And you're in their element too. So they're going to really act themselves.
I've definitely had to call Adult Protective Services a couple of times. Definitely had to get people evicted from their homes because the living conditions were horrible. Like you couldn't even walk through, otherwise you might fall through the floor. Horrible. Yeah. So I've seen a lot.
It sounds like you do not recommend nursing for anyone.
I recommend nursing for people who like to help, who want to care for people, who want to help people in tough times, and just be that.
But before you got into it, did you have an idea of what you were getting into?
I had no idea what I was getting into. Definitely. And it has definitely changed. I feel like healthcare as a whole has changed. It's more of a business than healthcare now. So my perspective definitely has changed since I became a nurse. My advice might not be the best.
Yeah, it takes a calling, really, man.
Yeah,
you have to be called. You have to be called to do that. Like you have to be. Those nurses, the ones that do their job right, like Nurse Maria, they are angels, man. And you want to have that good nurse, and you like to see that good nurse, and you hate to see that really bad nurse. For real. So
yeah.
We definitely appreciate everything you do, Miss Nurse Maria.
Thank you. I really enjoy what I do, and I just hope that I can, just change and affect other people's lives as the years go by.
So colon cancer, I'm about to hit 40. So you're telling me I need to get screened.
If you definitely have changes in your bowels, you're not having bowel movements regularly, you're having bloating, abdominal discomfort, diarrhea, constipation, all those things. If you're experiencing those, then you definitely want to think about getting screened.
Okay, so I don't have to get screened just because I turned 40.
Correct. Your doctor may still want to screen you anyway. But yeah, just because you turn 40 doesn't necessarily mean you have to, because, some providers may say, if you're not having any symptoms, you're not having any concerns, don't worry about it. But there are some providers who will start to screen you at 40.
Okay.
All right. I think we're going to let you go.
Yeah, we really appreciate your time, man. You was amazing.
Absolutely.
Yeah.
Amazing.
You're awesome.
Guys, you got a really good treat with RN Maria. She was very, very knowledgeable. And we definitely appreciate you coming through.
Absolutely. I definitely enjoyed it. I hope to be a guest again sometime soon.
Yeah. No, I was gonna ask you, are you willing to come back to the podcast?
Oh yeah, absolutely. This was dope.
All right,
Yes,
cool.
Yes. We'll get a panel of nurses up here.
Yeah.
Yeah. That was nice. That was nice.
All right.
All right.
Maria, thank you.
You're welcome.
Love you.
Love you too.
That was too personal, right?
No, not at all, man. Not at all.
Good looking out. Thank you.
You're welcome.
Have a good one.
You too. Bye. Bye, Jonathan.
All right, bye-bye. Nice meeting you.
Bye. Nice meeting you too.
That was dope.
That was cool.
Man,
Thank
dope.
you. Thank you for listening. Check out the podcast on Spotify, Anchor. Where else are we?
Google Podcast.
Google, Apple, Overcast, Stitcher.
Yeah, man.
Just search for The Formula Production. We should pop up. And follow us on Instagram at The Formula Production. Follow us on YouTube at The Formula Production. And on Twitter at The Formula Pro.
You can follow me on Instagram and Twitter at Boot Leach.
Follow me at Speechless417.
That's it, man.
Get that cancer screening,
Yeah,
man.
get that screening, man.
You gotta get it checked out. All
Faith,
right.
dream, hustle.
Repeat.
That's the form.
Deuces.